ones or the GLP-1s and the dual peptides. How many of you are using these drugs? So I see quite a few hands going up. And how successful you think every time we've used GLP, just using the drug has been? You think there needs to be something more beyond just the drug, and which is where today we have this session supported by Healthify, which is digital support for weight loss with GLP therapies, and I have a panel of experts. Dr. Krishna Sheshadri, introduced earlier, senior endocrinologist from the city of Chennai. Dr. Supratik Bhattacharya, again, an eminent endocrinologist, diabetologist from the city of Kolkata. And joining them very soon would be Dr. Banshi Sabu, the organizing chairperson for DRS Cody 2025. So let me start the conversation and take this to a case example. The question is, when medication alone isn't enough, do these questions come up when we are using these drugs? Intolerance to medication, aversion to food, eating as reward, no lifestyle support. These are the kind of patients that you see in your clinic. But the statement that I just made and the slide that you see up is pretty vague. What exactly are we trying to convey? And to that, let me ask Dr. Krishna Sheshadri to start taking up these pointers that we have and your thoughts on the patients that you see in the clinic and whether medications themselves are enough. Dr. Krishna.
Right, I think I'm going to take a couple of minutes. To understand this, we need to understand the biology of eating, right? There are two parts to the biology of eating. One is, it is controlled homeostatically, meaning there are signals that go to your brain that tells you the metabolic requirement of the body. I need this much carbs, I need this, I need this. This is done acutely by ghrelin. On a long term, it's done by leptin and insulin. So that is the metabolic part of it, which is homeostasis. But for most of us, food is also a reward. This is done by hedonic inputs, our memory as children, our own taste. For example, the taste receptors in Europeans versus Asians are very different. We like it a little more sweet than the Europeans can tolerate. So, taste. Our exposure to childhood, for example, in the Netherlands, during the famine in the 40s, because of the war, there was an explosion of eating habits after that place. So a lot of these are wired in, for example, I'll tell you, my father grew up very poor. So his one thing was that everybody should eat well. That included the people who came into our house and they would be fed to their gills, right? So past experiences, each of these develop, give you the reward system. So so you like certain foods and then you tolerate certain foods. The second part of this is two hormones. One is the endorphins, the second is dopamine. Endorphins program a likeness for food. Dopamine programs a motivation to get food. You may like something, but your satiety may say, look, I may like it, but I don't want to take it. But wanting that food is maintained by dopamine, right? So what do GLP-1 receptor agonists and others do is, while they also work at the metabolic level and alter the sensations that we have, they alter GLP-1 receptors in the hypothalamus, they work at the level of the liver, they work at the level of the hindbrain, which is the predominant area where the sensations come. They also work at two parts. One is satiety, the second is aversion. Aversion is given at the area of the, what is it called, striatum nigra in the corticolimbic area. This is from the area posterima, into satiety. Now clearly there is a dissociation between the two. That is why when you see patients, you will generally, I'm not able to tolerate this drug, really has many connotations. That's really what I was coming to when I looked at the biology of this. One, it could be that I have an adverse event to this drug, commonly nausea, vomiting, and now the GLP and constipation. A lot of the reasons the constipation is actually the food is reduced, and that's really why they're complaining of constipation. But with the GLP GIP combination, at least in the south and the east, there's a lot of diarrhea. So adverse events. These are true adverse events. I have nausea because of this. And remember, people, we used to think that the nausea is the way it is working, but that's not true. Second, an aversion to the food. For example, I'm not able to, when I see salty food, I absolutely can't do this anymore. There's the second part. And this is also part of it. The third complaint that you will see is, doctor, it's not the kind of food I take or anything else, but the moment I take a small amount of food, I can't eat anymore, which is exactly how the drug works. And then yesterday I had a patient who said, look, doctor, you gave me this drug. I definitely wanted to go and have a rava dosa at Woodlands last night. I had this for lunch. I went ahead and somehow finished the rava dosa that night. And the next day morning, I threw up all night. So if you look at these four things, one is clearly drug related. The second and third are also drug related, but the second is an aversion that is not the same as intolerance. And third is satiety, which is preventing you from overindulging in the food that we take. Lastly, of course, is this, that if you have your higher cortical functions are still not telling you that, eating so much is a bad thing and you need to get off it, you get this fourth part, that you'll do something, you'll vomit, and then still go and eat, and there no drug can help you. So these are the four parts I thought would be useful for us in the next 22 minutes to dissect out in patients and talk about it. So Pratik, I don't know if you have any comments on.
Yeah. So I totally agree. So we have a hunger center, which is the lateral hypothalamus, and you have the satiety center, which is the medial hypothalamus. And the medial hypothalamus, goes and gives a negative feedback to the hunger center. So it's usually under the negative control. So as he was saying, you have the area postrema and nucleus tractus solitarius, and these are related to the nausea, vomiting sensation. Then you have the delayed gastric emptying time, for that matter, which gives you the sensation of bloating, so as to say. And then you have the vagal afferents that are also related to the vomiting sensation that comes with it. And then you have the areas of the hedonic eating, like the amygdala, which is, they send out negative feedback, and that pleasure eating part is cut out. So the body gets what your body demands, but you can't go ahead and eat too much. And it usually preserves your appetite for healthy food, whereas the carb-dense food, the fatty meals, you can't have a large portion size, even if it is sitting in front of you. So that's the best part of the GLP-1 receptors. The way it works is it cuts out the pleasure eating, but for those kind of calorie-dense food, which is going to actually be detrimental for your health, and preserves the appetite for healthier food.
Okay, so what we're going to do...
Just to add, 1 second, and I think all of us need to remember one thing. While we call these GI side effects, these are not GI side effects, they are CNS side effects. I think that we need to understand that the side effects are maintained by your brain and not by the... Go ahead, sorry.
No, so just said the reason that we're having this session in the evening is, I was well aware that you guys are going to take the fun out of eating completely. So that's the reason we didn't do the session in the pre-lunch period. I'm going to be asking all the three panelists to, it's time. The larger essence of this conversation is, we have these wonderful drugs today. are they doing enough, or do we require to go beyond that? And as we introduce the subject, this is the era of digital technology and digital therapeutics, which is entering as an associate to the clinician in every field that we are moving in, whether it is monitoring of diabetes, whether it's management of diabetes, whether it's chronic weight management. So when there are great drugs coming in, they require additional support, and which is where we want to take this conversation to. So let's look at these profiles quickly. 46-year-old female, BMI 33, started on GLP for obesity and pre-diabetes, has nausea, cramping and vomiting. The patient says, I've lost a few kilos, but I feel sick all the time. Is this really worth it? The challenge for the physician is balancing the therapeutic benefit with the tolerability aspect and the risk of early discontinuation, which I'm sure all of you have experienced, that more so with the earlier GLPs, probably lesser, but that happens even now. What can we do? The question that we are asked, or we should be asking ourselves, is do you feel you have the right support system or team in place for these patients? So I take the question to Dr. Banshi. Let me start with this, not only the case, but asking a question. Is GLP for every physician to use, or having a support system is absolutely essential?
So it's very, very important for a support system. Even not, there are many non-physicians, or some of the times even patient is buying on their own and taking it, and they don't get the benefit as required, rather they get more side effects. So its need is there for a complete support system. Even when you start it, a physician has to teach, educate, as he has very rightly said, it's not GI side effects, it's our CNS side effects, and that also you have to explain the patient in advance. They are not, I normally tell them it's not even side effects, these are the effects of the medication. And you may feel fullness, nausea, and you should not worry for all these things. So to continue these patients on a long-term therapy, they need a support system. And where digital engagement definitely helps these patients in the long run. You have said this particular patient, after the few kilos of weight loss, now she is nervous, she is not ready to continue, she might have changed the physician, she is discontinuing the therapy. So I think a busy physician who is, mainly concentrating his practice on an acute management of the things where, symptoms and writing the medication, immediately seeing hundreds of the patients may not be the right one, or the person who is not having the supporting system. So you don't have the educators, social support system, or you are getting the patients from distant places, then also you will be able to see them more frequently. And there the digital therapeutic, or further they can be connected with the digitally, these patients are very, very important. We are practicing in a town which is having a lot of patients coming from different parts of the country, like he is based at Chennai, Kolkata, or you are in Mumbai or Ahmedabad. So from 500 kilometer patients are coming to you 200 kilometers away. They will not come to take every week or every alternate week or every 3 weeks.
True.
So they need a digital system for them to continue.
Great. So I think the point being made is everybody should be using these drugs, but everybody cannot have that kind of support system, having a counselor, having a diabetes educator, a nutritionist, an exercise expert. And all of this support system is important for you to get the results, the ideal results from these drugs, and which is where lies the strength of these systems. So let's, you have another patient example, and then I'll take it to Dr. Krishna. 29-year-old male, BMI 30 on GLP for 2 months, significant appetite suppression, unintentional eating, just minimal, less than 800 calories per day. The patient says, I'm just not hungry anymore. Food feels unappealing. I know I need to eat, but I can't force it down. So you'll have some such patients whose appetite goes down drastically. The challenges for the physician is nutritional deficiencies. And how to encourage the healthy eating. Do you really have the means and time to guide on the right kind of protein nutrition? How to handhold such patients who are having severe nausea or appetite suppression? Dr. Krishna, can you do something, or you need help of somebody else to do this?
So there are two parts to this. One is, I think let me make two statements. One is the care of the diabetic patient, especially with chronic care, cannot be for 5 minutes in a doctor's office. I think the moment we realize that, we understand we need more people to help us. This could be a digital tool, it could be a monitoring device, it could be a person who's calling up the person and asking them, and somebody who has more time to actually dissect it out and understand this. The second part is, Something that I read, which I really like, is that pharmacotherapy has gone from cure to subscription model, which means that every drug is going to come and tell you that you need to take it for a life. And the moment you tell them, look, this is for the rest of your life, you've already lost a battle simply because they've lost their will in many, many places because they're resigned to it. So what is the via media in all of this? I think the first is, in this particular patient, for example, this is not an intolerance. This is an effect of the medication that is creating an aversion to certain foods, right? So you really want someone who talks to them and says, look, which are the foods that you're averse to, right? Usually, oh, I love to go and have chips, I'm not able to have them anymore. Okay, fair enough. You can't stop it, but can you take 2 of it? So someone who handholds them and reviews this on a regular basis is very, very important in helping them. The way I talk to patients is this, that the medicine is so doctor, can I do this without a medication? I say, no, you can't. I'll tell you why you can't do it with medication, because you've come to a point where you need a crutch. The crutch is the medication. But if you're only going to use the crutch and not strengthen your limbs, you're never going to walk. The digital support or my nutritionist calling you and supporting and you doing self-improvement based on the tools that we give you is the strengthening exercise that may help you come off the crutch or use it to a lesser degree or be dependent on a lesser degree. So as Krishna says, abhyasa tu kaunteya, the coach is like helping you improve yourself and change the way you eat so that while only 19% of patients will ultimately come off the medication, you could be one of those 19%. So two points. One, don't think that 5 minutes is the end of the life of your patients, because their entire life is beyond those 5 minutes. Second, you need a way by which their data comes to you, that and this is not, fill it, shut it, forget it disease. That's what pharma wants you to think, but really you need to help them make those changes. And I don't think any of us are equipped to make those changes without a team. It could be your own clinic, it could be a digital platform, it could be someone who or a coach who works with you. My only worry about coaches is suddenly they decide to change their medications. Somebody decides to suddenly send them to your. Most doctors fear this, that they will send you to some other doctor or will recommend 6 almonds for breakfast, 2 peanuts for lunch. No. Somebody who understands what you believe in, who works with you and helps them understand how to use these drugs, how to approach them. I think that's where it is.
Okay, thank you. So we have 10 minutes on this and I want to ask pointed questions.
Yes.
And Banshi or Supratik can take this. Should a family physician use these new drugs? And if so, what tool should they use? Is digital therapeutics more an allied to a family physician without the support system, or more an allied to a specialist who has all the support system? Quick answers to quick questions is what I'm requesting for.
So family physicians should know about the subject. They should know that there is these type of drugs are available. I'm sure many of the times when you are prescribing, they may go and ask them. But I think they don't have the supportive system, or neither they have sufficient knowledge to understand the side effects, when to give, not to give. They may listen and see sometimes from the social media, and I don't think they are the right person. But again, now family physicians, other than Mumbai, in other parts of the country, a number of family physicians are less. But definitely, if they feel that they can write it, it's not like they can't write. In India, one can write. So, but then they should have supportive system, and I think they need more supportive system like a digital therapeutics for them.
Okay. So,
but your
again,
question was there, the nutrition deficiency and loss of lean muscle mass. That's
Yes.
very, very important. And how to encourage a healthy intake when medication blunts the appetite. So these are 2 very, very important, and that requires a very regular nutrition counseling, monitoring, regular follow-up, asking them and motivating them to take healthy food and to take more protein diet, for lifestyle to change, going for exercise, doing muscle mass strengthening exercise. All those are very, very important.
So Supratik, the question to you, when you start these newer, more effective GLPs and dual peptides, what should be the frequency of follow-up? What should the physicians here tell? How often should these patients follow up with you in the initial days after you've started? And body composition analysis. So for all of you, the BCA machine is there in one of the stalls outside, and all of you are welcome to do your own body composition analysis, look at your own muscle and fat mass. It's important for us to know. How often should do the BCA where it's there? These two questions.
Yeah. So I think the whole idea is to empower the patients at large. And as I say, reinforcement is needed. So that 5-minute conversation that we have with the patient is probably not good enough. And that needs to be, backed up. They would be signposted to somebody who would be having the same conversation again. And it's bound to happen that they are going to come back and ask the same questions, and they need a one-to-one support. Now, body analysis is done for me at baseline and at each visit. So usually, the protocol is when you're stepping up the dose, it's in dose steps, and then you go like every 4 weeks if they can tolerate. But I'm saying that you don't need to force up titrate. You can jolly well make them stay back on the same dose as long as they're connected to you. You can always ask for their feedback, and that's why that support is very much essential. So that when they go back and start on the medication and they, face the challenges, they can get back to you. If they can't, find you directly, there'll be somebody in the team who'd be addressing that, and that's why you need that support that, they'd be talking to you. You had already done that conversation before. You'd have talked to them about what challenges they might face after starting the thing. But once they are actually facing it, they want to have a chat with the doctor, and this becomes much more easier if you have somebody in the team who'd be catering to them on a one-to-one basis.
So we're going to open this up for last 5 minutes to all of you who have questions on GLP usage, to the 3 experts here. So keep your questions ready. A quick question, Banshi. Patient comes and tells you, you started on this drug, doctor, but खाने का मजा ही खत्म हो गया है. I used to enjoy eating, right, or drinking or whatever at the end of the day, and I've worked hard enough, but I just don't enjoy that. You've taken away the joy of eating. Do you hear that, and what to do about it?
This is, I think, what we should explain in advance also. It's not the joy which is important. You also have to tell the patients about the health and benefits, because ultimately a healthy life is going to give them a lot of happiness. And we also talk to them about the cardioprotective and then the fatty liver part, which is also a bigger person with obesity, have all those complications going to happen to them. So I always explain them, and we also ask them, what you are saying that this is, or by seeing this type of foods you would like to have, you can't resist yourself. So as here said rightly that, the quantity can be small, and then slowly we change it. And that's the reason we need more follow-up, these patients, because they require a lot of motivation. Otherwise, they will stop it after 1 or 2. So initially, when in last 4 months, what I have done is, in some of the patients, we have given them and we ask them to come next week only. Now, after 2 weeks or 3 weeks, or on telephonically, we are connected with them, or we ask them, if you develop any problem or any issue, please call us. And all these things we are doing. So this digitally engaging them will definitely help. Now, this digitally does not mean that all the time you have a third party. Your team can be digitally connected. You can be connected.
But
on
how do you help
WhatsApp.
with the joy of eating not there on digitally?
That's what you have to tell them again and again, and motivate them for.
Yes, Krishna.
So, see, I think Indians generally understand when we explain it into their own philosophical terms sometimes, that we are not necessarily the bogies of the West. You tell them, look, you know that this is bad for you, but I understand. The reason the joy of eating is that they associate food with a reward. The medication is now doing what you should be able to do yourself, which is to dissociate food from a reward. And how is it done? It's done with practice. Use a discriminatory function. Every time you think about food, think that is this something that I really need, or this is something that I'm just doing it for the pleasure of it. And that comes with just practice. It is abhyasa tu kaunteya is the right word. It comes slowly over a period of time. Then why do I need a drug? You need a drug it is like, taking a dip in the Ganges. All the years of accumulated fat you need to get rid of. So that the drug does. But can you prevent this from happening? By adopting these practices, and that comes by training your mind to think healthily. I think that's really where, time with the patient, and if you can't do that, a coach doing it makes that difference.
Essential.
That engagement is what is that engagement doing? It's creating that change through repetition, through reinforcement of adopting the healthy lifestyle which we've lost. That dissociation from the reward is the key.
I think that's important. The essence of whether we do it or digital therapeutic is the engagement. I invite questions. Any of you interested in asking questions, please come up to the mic in the center and then line up there so we can take the questions. Yes, sir. I'll start with, I have a lot of questions here, but I'm going to take a pause here and let the audience
Hello,
take
sir.
that.
My question is that in the Indian scenario, whatever you have said, it is a very pertinent point, important thing. But apart from all those things, in my opinion, we must study the genetics of the patient. How the genetics is going to affect the GLP-1 respondents and non-respondent patients. What's your opinion?
Quick answers to these questions.
So remember that there are no genetic markers of GLP response. So there's no blood test you can do for it. 10% of your patients' glucose will not come down. 10% of your patients' weight will not come down. So unless you try it, you'll never know who's going to respond or who's not going to respond. Everything else there are markers, but for GLP-1 response there is no marker.
See, nowadays a lot of problems are coming with and the retinopathy is concerned with GLP-1. And the cause is not known, and lot of patients are suffering from retinopathy. What we have done, how far we have come for that? Retinopathy.
Go ahead, please answer.
Diabetic patient.
I don't think a lot of patients have this problem. It's a rare problem.
No, sir, I have 3-4 patients I have seen.
You have three patients with NAION. Then you should report it, sir.
Now, is it NOION you're talking about or just worsening retinopathy? Here, sir. So worsening retinopathy.
Those who are on GLP-1.
On GLP-1, they have increase in retinopathy. It's a complication, normal complication of diabetes also. So they have diabetes retinopathy. When you are tightly glycemic control, when you are tightly controlling the glycemia and with GLP-1, there may be slight increase in it. But if you are talking of NION, it's very rare. It's not like very common side effects. We should explain the patient about the common side effects which they may have. Again, as I told you about the GI side effects or the diarrhea some of the patients which they may have. Sometimes you may have to discontinue only for those reasons. It is not recommended to screen them also because it's not a very common side effect.
They are all related with
Any
the
other
diabetes.
question?
So I'll quickly explain that you have to screen the retina at baseline, and then if you see background changes, not worrisome, non-proliferative, be watchful, and early worsening is known, but it's not like you can't use it. In fact, if you're using it for a long term, you probably do justice. But in advanced retinopathy, you have to be very, very careful using anything which is robust in bringing down the A1C very fast. Not just GLP-1 receptor analogs, it could be
Insulin
insulin
or
therapy.
any of them.
So they're all known to cause early worsening of retinopathy, but that doesn't warrant you to stop using it
Thank
in
you.
background retinopathy or
Thank you.
early
One
stage.
more
Sir,
question.
we should allow
One
the
more
next-
Sir, I'll
question.
let the next doctor
Sir.
take the question. Here, sir.
Sir, nowadays diabetic patient goes for the surgery, invariably we stop for the medicine for a day or two. And now there are cases are coming where the doctors, they recommend to stop the GLP-1 before any operation.
Banshi,
Why?
I'll take this. Sir, here. You have a complete session on this of perioperative management on GLP in this conference and you'll get that answer.
sir.
So sorry I'm cutting you short. I have another question and then we're winding up. But this, you'll get this answer in this conference. We've kept that topic.
Yeah, hello. I'm a family physician, and I have patients coming, non-diabetic patients coming for the weight loss, and now all these drugs are available, the information is available on the media. So they just come and ask me, how do I start Rybelsus? What is the investigations do I do? So like as a family, you said that family physician should use it with caution. So now the patient, the information is available everywhere. They know the names of the drugs. So I just want your opinion, like if it is a non-diabetic patient,
So Rybelsus is not for anti-obesity.
Yeah,
Rybelsus
so-
is the oral semaglutide which is approved for as an anti-diabetic agent. Injectable semaglutide which is available in India is Wegovy or Mounjaro which is available.
Mounjaro, yeah.
Yes, dual, which can be given. But in an obese person, I think first they also need to be investigated because they may have underlying other problems too.
Right.
And each and every obese patient should be investigated for comorbid conditions and all other things. It's better. And then you should ask them that these are the medications which are available. It is best that they should take from those doctors who are regularly prescribing it and they can follow it also.
So
and
if-
you can also follow these patients once they are taking from the consultant to whomsoever they are taking.
Right.
And
So
then you
if
can
the-
follow these patients
If the
regularly.
patients are above 60, I expect some comorbidities and go with caution. But now the younger patient, now
No, but
because-
even for the comorbidities, these are the medications which are actually preventing. Even with the patient with established cardiovascular
no, but
disease also.
if the
with
patients
fatty
are
liver disease
younger,
also.
30, 35, and if they want to use it for the still,
So,
Ma'am,
The caution.
one thing to be cautious about, if it's an obese patient with gallbladder diseases, they might end up in pancreatitis. So you be very, very cautious who are coming to with gallbladder stones, and then be watchful about starting and not monitoring them. And you have to tell them about the red flags, and then if a pain develops and if it's, something of a red flag nature, they need to get back to you
so
immediately.
I'm going to stop all of you here because we're way out of time. Sorry, Dr. Rishi, Smruti, but there are multiple sessions on these new drugs today and tomorrow, so you will all get the answers. With this, let me thank the panel here.